Okay, good morning, everyone. It's the 28th of July. I know lots of people are on holiday this week, so hopefully some of us are getting some sunshine somewhere, and I hope you weren't travelling to Spain. So I've got a couple of updates for you this morning. First of all, I just wanted to make a correction from Friday's webinar about the treatment of anosmia post-COVID. So I had said to you that fluticasone was the first line and you could potentially use Dymista. But we had a confirmation with Dr. Elliot Benjamin. I had back, and he's actually said that we should use fluticasone unless they have allergic eye and nose symptoms, i.e. sneezing and itching, and then we should use Dymista. But really, for post-COVID anosmia, we should be using fluticasone, either the spray or the drops. I just wanted to make a correction from Friday. So the things I wanted to update you on this morning were changes. First of all, changes to the 2-week wait lower GI pathway. So some very minor tweaks there. So in the last few weeks and months, we've been used to doing fit tests for patients, but the criteria is slightly tweaked to say that we can now refer, in the absence of a fit test, in the following 3 circumstances. The first one being any age with an unexplained rectal mass, any age with unexplained anal mass or unexplained anal ulceration, and finally, patient that meets the NICE NG12 criteria, or there is strong suspicion of colorectal cancer criteria, but fit test has not been done, and therefore we should use the additional clinical information box to provide full clinical details of the reason why we feel they need to be invested by secondary care and why fit test was not performed. And we can still arrange the fit test, or they may still arrange the fit test. The criteria is on the form, and when you look at the form, so I just thought I'd give you a heads up. The next thing, I've had lots of questions this week about phlebotomy being the hot topic. And last week I told you about using the words urgent or essential. And I know from colleagues there's been some confusion, certainly with some of our providers. So please do feed them back to me. I've had lots of people say that, patients have gone to the appointment or phoned up and actually some of the staff haven't understood what the word essential has meant. We have tried to reach out to all the providers and make sure that all of their staff are aware, so no patient gets turned away, but I'll just explain it a bit better. If we put urgent on a form, what that means is that patient should have a blood test that same day if they call sort of before 2 o'clock. Whereas if they called at 2 o'clock and all the blood tests were full, and they didn't have the word urgent but had the word essential, they probably would be told either one of 2 things. We can give you an appointment for tomorrow because they're only booked 24 hours ahead, or they might ask them to call again tomorrow morning. So because of the way they're booking in all providers, it's not just Rule 3 or CLCH, it's across NCL, all providers that are doing phlebotomy. They're only booking for that day or the next day. Okay, they're not pre-booking 6 weeks ahead for a number of reasons. A, because actually they're trying to offer appointments within 24, 48 hours to make sure they don't build up waiting lists. And number 2, we don't know whether a member of staff is going to go off sick or how many members of staff are going to go off sick at any one point. So they can't forward plan. And so the idea is they're trying to do all the bloods within 24, 48 hours and therefore not book any further ahead than that. And just to remind colleagues that the capacity at Finchley is now back to pre-COVID, so that they've got 5 phlebotomists instead of 3 to provide 800 tests per month. Edgware is coming back on board. There was a delay with that. We'll have, again, 800 a month capacity. Rule 3 has got nearly pre-COVID capacity. And as you know, Barnet will not be offering phlebotomy because it's a hot site. So I just wanted to clarify that with you. The next thing I wanted to talk to you about this morning was really in secondary care, how do we prepare ourselves for a second wave? And there's been a lot of guidance released about that. And really the emphasis is on about us making sure we can handle safely sort of remote consultations. Okay, and that can be either by phone or video or any other electronic means. So we need to make sure that we've got staff training, so that's all of our clinical teams, including our clinical pharmacists and nurse practitioners. And it is a steep learning curve, but it's really about how we can ensure that we're doing that in the next few weeks. But we also need to be really conscious that where possible, patients will still need to access face-to-face consultations. So as you know, we've got the Hot Hub if you think somebody needs it, or they've got home visiting service. So do remember about those services for hot patients. But really for cold patients, we should continue to offer them face-to-face appointments. And in particular, I talked to you a few weeks ago about learning disability checks, and the guidance is clear that if you can do a learning disability check on the phone or virtually, that's fine. But equally, if that patient needs to come in because of a communication barrier, or it's better for that patient, then you should really be bringing that patient in for a learning disability review face to face. The other thing that's really been talked about in preparation is that a lot of people complained about shielding advice. And if there is a second wave and people are asked to shield again, for example, just to remind what the government did, which they often do, is pass the buck back to the GP. But effectively what they said is that if anyone was unhappy or you felt that they should actually be shielding, we have the discretion, and it's the word discretion that I've used, to extend the shielding to those patients who might benefit. So it's really our discretion to do that. It's also they're talking about improving communication and ensuring virtual means of contacting our care homes, and then making sure that our facilities are adequate and clean in preparation for a potential second wave. So there is more guidance coming out about that, particularly the BMA and the MDU are preparing some guidance for us about that as well, and about how to avoid complaints during COVID-19 pandemic and the change in services. I think that's really important. I'm just going to post a web link in the chat bar, and this web link is for colleagues to look at, and this talks about the key principles for intimate clinical assessments undertaken remotely in COVID. And there's lots of guidance flying around, but this is a particularly very useful actual document, and it talks about us not receiving intimate images, and if you did receive them, making sure they're not saved onto the patient's record. And it's the same thing. So if you examine somebody's intimate area in the practice, we certainly wouldn't be taking pictures of that area and popping it into their notes. It's the same thing. So if somebody did send you something, even though you asked them not to, then what's really vital is that we delete those images and make sure they don't get saved to the system. And then you inform the patient. So there's when patients are using eConsult, it does tell them not to send in intimate images, and the same when they're doing something with AccuRx. But of course, some people can just press OK or yes and actually not read what it's saying. Often we just click. Sometimes when we're doing things and actually not read that, it's asked us not to send something like that through. So just be aware of that. It is a criminal offence for us to actually receive images and store them for children in particular. And we've got to be very mindful that there is a strict law about it. I've just got a couple of questions about phlebotomy that have come up, and then I just want to touch on audiology. So Edgware Community Hospital is starting to provide phlebotomy, but there has been a delay in the restart. It was supposed to restart last week, but has been delayed, and they're working on restarting that for Monday, but they're trying to restart it for this week if possible. And I understand that there was a problem with staffing, and that's why it wasn't restarted. I'm just going to look up what the capacity is going to be when it opens up, and I can just tell you that now. So the capacity for Edgware when it opens up pre-COVID was 1,500 per week, and then when they open up, they're going to open at 1,300 is the aim to open up for capacity when it opens back up. So it's going to be quite significant, nearly the same as pre-COVID. The final thing I wanted to update you on is audiology. Our community provider, Audiological Science, will restart services from Monday the 3rd of August. That's next Monday coming. But they will not be doing earwax removal. Currently, that service will remain suspended in line with Royal College guidance at the moment on the NHS, and along with NCL CAG. And what we're being told at the moment is until the acute providers restart wax removal on the NHS, our community provider cannot restart safely. So they'll be restarting audiology on Monday. Referrals, or you can make new referrals as of tomorrow morning via the RMS, but what they'll be doing is working through the backlog to clear patients. Now they've got some really interesting technology in that patient. What they've been doing over the pandemic, just to give you a heads up, is that they have been remotely reconfiguring hearing aids. So they've managed to get some new technology which is compatible with the hearing aids that they're fitted. So let's say that a patient says my hearing aids need a tweak or they need changing, and patients can download an app, or their family members can download an app. It links via Bluetooth to their hearing aids. They're then put in their details, and then the provider can see their hearing aid on the other side and can make some tweaks, send it to their app, and then the patient's hearing aid gets updated remotely, and then they can go into the app and say it's great, I want to accept this change, or they can go back and reject the change, and then it'll go back, and then they can write a comment saying was too loud or wasn't loud enough or whatever, and then the provider can go back and tweak that all remotely within minutes. So it's really fantastic technology which saves people coming into clinics for a tweak, and it can really work in this COVID world. So that's really exciting that the provider's got that on board. And with regard to wax, people that were referred pre-COVID, they've been managing them virtually by providing telephone advice to advise them to use olive oil, sodium bicarbonate, and some of those kits like NeilMed ear irrigation kits, which are very safe to use, and they're about £10 on places like Amazon, which we've been recommending patients, which are still things that people can do to remove wax. I'm going to pause there for any questions from colleagues. And as always, if you think of anything, just let me know, pop me a note in the chat bar. Otherwise, I'll see everyone on Friday at the same time for a further update. And this Friday, I'll give you a further update on where our community providers are, if possible, and a further update on where the phlebotomy is, and diagnostics if I have an update by then. I'm also hoping this Friday to have an update on some cardiology stuff as well. Keep you posted. Thanks, everyone. Have a good week, and I'll see you Friday.
Thank you. Thanks.
Thanks, Nick.
Thanks.